neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed.
Good evening. We are going to talk about neurosurgery today. It is a specialty dedicated to the diagnosis and treatment of issues affecting the nervous system, and that includes the brain, the cervical spine, peripheral nerves, and structures specifically, because we're looking at surgeries and how to fix stuff that shouldn't be there, or how to fix things that are not correct at this point. We're specifically focusing on pediatrics tonight. And we have a veteran with us this evening, and I'm going to introduce you to those two people in a moment. But I want you to be aware that this is a live program. So please call us with your questions at 881-0013. This evening's program is underwritten by the El Paso Children's Hospital. And again, we want to say thank you to the Texas Tech Paulo Foster School of Medicine for providing medical students to man our phones. Today we have with us Josh Gardner, and he is great about asking what exactly is it that we need. So he's going to be taking down the questions and sending them my way. So please let him know what you'd like to ask. And again, this is about pediatric neurosurgery this evening. We also want to say a huge thank you to the El Paso County Medical Society for doing the show for almost 25 years now. It's been a long time, and they keep going every single month, several times a month. I'm Catherine Berg, and you're watching the El Paso Physician. Good evening once again. I am Catherine Berg, and we have with us Dr. David Jimenez, who is a neurosurgeon who specializes now here in El Paso. He came to us via San Antonio, and we're very, very lucky to have him here. He is the medical director of the Pediatric Neurosurgery at El Paso Children's Hospital. And also with us is his right-hand man, so to speak, right-hand woman. Right? Don't give me calls. The right-hand woman, this is Sandra Flores, and she is a pediatric nurse practitioner, and together they make a great team of what is happening here in El Paso. As I said, Dr. Jimenez, quickly what your title is. I would love for you to give an idea to the audience at home of who you are, what you do, and you said that you are a neurosurgeon, but you practice in all kinds of other areas as well, and that way there's some kind of a background when people have questions to ask specifically of you.
Yeah, great. Thank you for having me. It is a great opportunity to celebrate Neurosurgery Awareness Month, which is August. So I'm the director of pediatric neurosurgery at El Paso Children's Hospital. I am a doubly board certified neurosurgeon. I have taken care of both adults and children, but kids are my first love. And this was the great opportunity to come and service a community that really needed this kind of service, and to work at a great hospital with a great team of people.
And it's all about the teams, and that's where, Sandra, you come in. So when we're looking at who it is that we work side by side with every single day, that's where everything happens. It's where the magic happens. And Sandra, as a pediatric nurse practitioner, when you are side by side every day with Dr. Jimenez, give some of the day-to-day duties that you have.
Well, thank you for having me too. Well, our day usually starts when we have clinic. Okay. We come in, get ready for the day, go in, see patients, get history physicals, do their assessments, and you know, I present the patients to Dr. Jimenez. Dr. Jimenez then goes in and makes the plan with the patient, and then we coordinate whether it be surgery or any other kind of treatment that they may need.
So oftentimes I'd imagine that you and your staff, your team, your frontline people that get to interface with the parents. Yes. And the children at the same time. And that's something too that I think that you stressed last time we were here, that parents are such a huge part of this equation. We are talking about pediatrics, yes, but nothing can happen without the parents seeing and understanding and noticing things that are going on. On that note, I know that I kind of talked about what neurological conditions were earlier, but when we're looking at neurosurgery, it encompasses so much. I mean, just doing the research on this program, it just goes into so many depths. If we're looking at keeping this in an hour, which we have to, because that's what we have to do, how would you describe the encompassing issues with neurosurgery that you do?
So neurosurgery is I'm biased, but I think is a wonderful discipline of medicine. It deals with the most complex organ in the body, obviously. We all know how complex the brain is, made up of trillions and trillions of tiny, super powerful computers all connected that allows us to communicate and interact the way we do. One of the things that attracted me to neurosurgery was, we know a lot about the rest of the body, the heart and the kidneys and all that, but the brain is still this black box in a way. And so the challenge of really getting to know it. And so there are two main groups, right? You have neurology that deals with chronic illnesses and the like of the brain or the spinal cord. Or I chose neurosurgery because that's an area where you can literally make a difference immediately, right? So if a child presents with headache, nausea, vomiting, and all of a sudden we find a tumor the size of a grapefruit in the baby's head, well, we take it out.
A tumor the size of a grapefruit in a baby's head. I don't feel like it even fits in there.
Yeah, I mean, really, we've taken out tumors, half the head is filled with.
So I'm gonna do this is a follow-up question that's probably being asked a little bit too soon in the show, but it just goes along to what you're talking about. When you are looking at nausea, when you're looking at, and let's say a brand new baby, let's say the baby's not even a month old yet, but there's something off. And can tumors can babies be born with a tumor and have it grow that quickly? And the reason I'm asking that is when you're looking at different symptoms, parents immediately, especially if you're a first-time parent to a first-time baby, and you're looking at it and the doctor's like, oh, they're gonna be fine, or the next door neighbor's like, ah, my baby threw up a lot too, oh. What specifically is a parent looking for? And I'm gonna ask you that same question too, because I think that sometimes you get to do all the science in the background, but you're listening to mom and dad freaking out, like literally freaking out. So what is it that they're looking for? And then I'm going to ask you kind of the same question as a follow-up.
Well, yeah, so babies can be born with tumors, but most commonly they tend to show at around age 3, 4, 5, 6. So typically you have an absolutely beautiful, normal, gorgeous baby running around being a baby, and one day Mommy, I have a headache. Mommy, I have a headache. And, parents blow it off. It's just nothing. Then they throw up. Then they get throw up. And they have a headache. Oh, it's probably a GI bug or something.
Right. And that's what we all hope it is.
Right.
Yeah.
And then typically, eventually, it's like, wait a minute, something's wrong here. So then we get a scan, and sure enough, there's a tumor. It increases the pressure in the brain. So one of the things that parents should look for is the soft spot becomes full and tense, and the head begins to grow faster than it's supposed to.
So when you said that, because we were talking, and actually, Sandra, I'm going to take this on to you real quick, because I do want to talk about the head begins to grow. I don't know if this is the water on the brain that we were talking about earlier. So keep that thought, because I want to get right back to that. And you, Sandra, when parents come to you, and again, you're doing the intake, you're trying to ask the questions and figure out, where am I going to put you now? Do we go to talk to Dr. Jimenez? Do we, kind of carry us through what some of the questions are that you have encountered from different parents before?
Well, most importantly, like he said, the growing of the head. A lot of times the parents start noticing when they're babies. When they're little, they go to their primary care physician, which is their pediatrician, and they do measurements at 2, 4, and 6. When you get your immunizations, they do have the well baby checks, and that's when they start noticing if they are going off the curve, the growth curve, right?
Right.
Like Dr. Jimenez said, that's one of the biggest things that they see, the head growing, the bulging of the fontanelle. Babies are sometimes not...
Explain what the fontanelle is to people who don't know. Like literally take your hand and show
the fontanelle is right here. It's the, this is an anterior one, okay? This is the soft spot is what they call it. And when they're born with the front one and then the one in the posterior, but which usually closes early on.
Okay.
But when, like he said, the growing of the head, the bulging of the soft spot, and a lot of times what they also see is that the kids are not reaching their developmental milestones. There's certain things that they should be doing at certain ages. So that kind of cues them in as to, something's not right.
So when you're talking about the head growing and bigger than it should be, what ages are we looking at here? are we looking at, like you were talking about, 0 to 3 years old, or is this something that happens earlier?
Earlier,
Okay.
when they're babies,
Okay.
because your head grows about 2 centimeters per month for the first 5 months.
Okay.
And then it slows down, but that's where the growth curve comes in. You know, if you start seeing that there's a deviation, like, you know, 1 month it was here, and then the next month it, you know, jumped 2 curves, two lines, and that's when you start saying, you know, something's not right here.
Right, right. So back to that, because we are talking about, again, it was hydrocephalus, is that right, what you were talking about?
Yes.
So let's go specific now as to what is physiologically happening. So we've got the soft spot, to keep it in layman's terms, and is there just fluid that's accumulating there that should be absorbed out, you know, a different way, or what is the body doing in that moment?
So this is a great point here. So our brain floats inside of our skull as if it was inside of a fish tank, okay? And where does the water come from? And the water is literally clear as the water we drink,
Oh, wow.
okay? There are specialized cells deep in the brain that take that water out from the blood and make it into what we call ventricles. These are chambers or caves inside the brain. So think about us having a faucet turned on inside at all times. And we make about 1/2 liter of this a day, constantly.
A
It's
half a
op-
liter a day. Our bodies makes
yeah,
a half a
yeah,
liter a day.
Yeah, constantly. It's
Okay.
a faucet is turned on,
Interesting.
and fluid is constantly going 24 hours a day from the minute we're born or before. So the water goes through a set of pathways deep in the brain, and then it comes out at the base of the brain and surrounds the brain and the spine, and so it helps to protect it. It does a whole bunch of things, right? Then there are specialized cells that take that fluid out of the brain, out of the head, send it back to the heart through the jugular. The heart recycles it, sends it back up the
So
carotids.
is this all within the venous system? I mean,
Arterial,
uh-huh,
the arteries sends it to the brain.
okay,
The arteries then, the brain sucks it out of the blood vessel,
okay.
makes it into spinal fluid,
Interesting.
goes through a whole set of
So
pathways.
it's like this filtration
Yeah,
system set
exactly.
up.
And
Okay.
then it returns to the heart via veins, right?
Okay, right.
So imagine your sink. Your sink is always going full blast, but the drains down at the bottom are open. But what happens if you block the drain, either
Right.
partially or fully? Well, the water
Keeps
spills on the
going and
floor.
going, right.
But water doesn't come out of our ears or nose, right? It stays inside and begins to compress the brain against the skull, putting pressure and damaging the cells.
That's the headaches that you're talking about.
Correct.
But again, you're talking about babies too, and sometimes they can't. With this condition, it's not something they can tell you. It's something you're physically looking at.
Right, so hydro, water, cephalos in Greek means brain. And so in babies, the head just keeps growing and growing and growing. And I took care of a baby whose head was 100, literally it was this big.
Oh,
and
my
he
goodness.
was 9 months old.
My
His
goodness.
head was this big. So we treat it, and there are a number of ways in which we
That
do
would
it.
be my next question. So how does
Right.
the drainage happen, and does it start affecting the rest of your body? Because if you're talking about 1 liter a day, and let's end with the one that's, you know, we're talking, that's over like an 18, 16 inches type thing. But let's look at someone whose head you're noticing. Parents are noticing the head is growing, and I don't know if is it soft? I mean, is the water outside of the skull? Is the skull actually expanding within? I mean, how I'm embarrassed I don't know this, but I'm trying to figure, is it something you can feel? Because, you know, water feels like a water balloon, but the skull's there. You've got the water on the brain, but then where is that barrier?
No need to be embarrassed. It took me 16 years of training
goodness
to learn
gracious.
this stuff. Really. No, so the fluid is between the brain and the skull.
In the skull.
And
So how does the bone
depending,
expand
so
that
there's
much?
two ways.
Okay.
Either the fluid accumulates between the brain and the skull and pushes the skull out,
Okay.
or the fluid accumulates inside the brain, pushing the brain out, which then pushes the skull out. That's pretty bad also.
Yeah.
So depending on there are multiple categories, and
Right.
we can sit here and talk about this for a while.
Right, right.
But there are multiple categories. Some of it can be treated with endoscopes and lasers and doing internal openings, which works great. I do a lot of that, and I've written a textbook on that area. Another option, which is the most common one, is where we put actually a little tube, a drain
Okay.
inside the brain. We run it under the skin, and it runs all the way into the abdomen. We put it into the peritoneal cavity, not in the stomach, but in that area.
Right.
That extra fluid gets absorbed by the blood vessels of the gut, sends it back to the heart. The heart sends it back to the brain, and that's called ventricular peritoneal shunting, or VP shunting.
And that way you're not shocking the system by just eliminating that fluid immediately. Would
Right.
that be part of that
Right,
as well?
and the shunts that we have now are programmable, and we can control them with magnets, and it's really fancy.
So when we are at, and Sandra, I'm going to go back to you in a second because I'm just fascinated about the ability of our bodies. You were talking about this 9-month-old baby whose head, and I'm thinking, you know, should be here, and how is the skull, number one, able to handle that? How did that, I'm going to sound horrible right now, but I feel like that would be something that would just blow up, right? How did that not happen, number one? Number two, once you get to that point, is there any kind of neurological damage that is irreversible at that point?
Well, unfortunately for this baby, the waiting 9 months with so
Right.
much pressure,
I
he
can't
was
even-
he was severely affected. He was blind, and he's still alive today and well cared by his parents.
Mm-hmm.
But the goal, yeah, there is a membrane that covers the brain between the skull and the brain. That's called the dura mater. In Latin means the hard mother, because it's hard like leather. When we're born, this is a fascinating point, the brain, as Sandra said, doubles in size within the first year of life.
Right.
So say you're 6 feet tall, you come back a year from now, you're 12 feet, you go, whoa.
Yeah, what happened to you?
But
right.
in the skull, because it's a round sphere going from here to here, you really can't tell that as much, right? First year of life, it doubles in size. Well, as the brain grows, what happens to the skull? Well, the skull passively enlarges and grows
Right.
in response to the brain below it. So in the baby that I was telling you about, as the brain expanded, the dura made new bone.
That is amazing that it can do, that your body can
Yeah.
do it that quickly.
So I can take a baby that comes out of mom's wound, take him to surgery, right? Take the entire skull, including the orbital rims, everything down, throw it in the bucket, close the scalp, and in 9 months the baby has a brand new skull.
Really?
Yeah.
Just regenerates a brand new skull.
We're bone factories when we're babies. Now it's
Right,
gone. If I
right.
put a hole in your head, you'll have it the
Yeah,
rest of your
I'll
life.
keep that little dent in my head for the rest of my life. I
Right.
get it. My goodness.
Yeah.
So, Sandra, I don't even know what to ask you at that point. So what I'm going to do, though, because I've got some questions that are specific to some of the other things that we're going to be talking about. So this is water on the brain. So old school, that's what people know as water on the brain. And then the drainage that we've talked about. I want to talk about brain tumors as well, because that, when we're talking about neurological issues and neurosurgery and tumor on the brain, you said that it's possible but not likely that a baby can be born with a tumor. And I would like to talk to you too about pre-op, post-op, etc. So let's talk about the most common areas of the brain, if that's even a thing, if there is a most common area of the brain where a tumor does grow. Where is that, and what is being affected by that tumor? And also throw in age groups. Let's say, 2 to 5 years. You were talking about the 3-year-old age a little while ago.
Right. Yeah, great question. So in the pediatric population, if you think of our skull as having multiple levels, right? Well, there's 2 primary levels. One we call supratentorial, which is everything about this level, which is where the brain lives, the cerebrum. And then below that, the first floor, not the second
I
floor.
like the first floor, second floor.
Is
that analogy.
where the cerebellum
Right.
and the brainstem live. High real estate, right? Brainstem keeps us alive,
Absolutely.
and cerebellum, balance, and all of that.
Right.
And then that becomes the spinal cord, and then goes into the spine. The pediatric population is most affected in brain tumors in the posterior fossa, or in the first floor.
Interesting. I would not have thought that.
Yes.
Okay,
Yes.
so we're looking
So-
near the brain stem.
Yes.
Okay.
So that's where the spinal fluid is on its way to
Right.
get out of the brain. So
Okay.
guess what happens? the tumor grows. What happens to the spinal fluid? It can't get out.
Right.
So the pressure goes up, ventricles blow up, kid gets headaches, starts throwing up.
Right.
Right.
And so I always think of tumors, and there's benign, there's malignant. I get it, but either way, it's fast growing. And if you are in a confined space like the brain, benign or malignant, at this point, yes, it matters. But if it's growing, even if it's benign, and there's pressure now in certain areas of the brain, and we're talking about the brain stem, a lot of the functioning is on the second floor, if that's correct, if I'm saying that right. So you now are the person that goes in there, and let's talk about, actually I'm going to take this to Sandra real quick, and feel free to cross speak with one another, but diagnosing this, right? When you're looking at, is it a CAT scan, is it an MRI, is it all of the above, is it asking questions, how long have you headaches for, how much is the nausea? How is your staff, the nursing staff, and prepping the questions and asking the parents, how does that all go down, especially the diagnosis? And again, feel free to kind of crosstalk with one another as well on that.
Well, I think sometimes when we see a lot of the patients that come in through the emergency room that come in with those symptoms, headaches, throwing up, being off balance.
And that's a big one too, because headaches, throwing up, you think that could be associated with something else, but being off balance, that is not normal for a child.
Yes.
So that's one that I would think that, okay, that's something I'd look out for.
So when they come into the emergency room, if they're suspecting something's going on in the head, they usually do CT scans because they're a little faster and than the MRI. And a lot of times, little ones won't stay still for the MRI.
Right.
MRIs take a little longer.
Right.
When they come in from a referral from their pediatrician, with those symptoms, headaches that just won't go away, they are not relieving any medication. We ask those questions, what other symptoms are you having? Are you throwing up? Are you having any dizziness? Are you off balance? Are you having any numbness, tingling, sensation to your extremities? Any visual disturbances, any visual changes? If the patient has not had any imaging, we don't require for them to get it. That we have them come in, we assess them, and then that's where, if Dr. Jimenez suspects that something's going on, we usually do order MRIs because of the radiation exposure with the CT scans. Okay,
that makes sense. And now that we have an MRI, what specifically are you looking for when you have that test in front of you?
Well, we scan through all the images and look for asymmetry.
Okay.
Both halves of the brain should be identical. So any asymmetry, any fluid buildup in the brain, any swelling of the brain, any shift of the brain, flattening of the tissues, and then of course we have what's called a blood-brain barrier.
Exactly.
It doesn't allow anything in there.
Right.
So we give contrast, put an IV, and the contrast, if it's typically a malignant tumor, will light up like a Christmas tree.
So that kind of leads to the next question. When do you know when it's time to go in? When it's time to, it's time to scrub up, go in, and I know that often you don't exactly know what to do until you get in there, but now with all the imaging, you can kind of see what you're going to be doing. So that decision right there, and I know that's a tough question to answer because it's different with every single patient, but you're looking at, and you said if it is a malignant tumor, things light up, it's time to go in. Is that usually done, say it was a person that came in through the ER, is that something you do that day? Is it something that you study for a while? And again, everyone's different, I get it, but maybe throw out a case study that you might remember.
Well, so you can have a patient who has mild symptoms, and then we get the scan, and mild hydrocephalus, otherwise the patient's doing well. We have time to sort of work them up a little bit. We have patients that come in almost comatose, very, very sick. And then we have to do something right away. So typically the first thing that I do is to drill a hole in the skull and pass the catheter into the ventricle, relieve the pressure, get control of the pressure inside of the brain. Then typically within the next day or within 48 hours, we plan to take the patient to the OR. Now, these surgeries, we're not taking out ingrown toenails here, right?
Right, exactly. It's
These
brain
are
surgery,
very
like literally,
right,
yes.
literally, very complex. So you require literally the A team.
Right.
And yes, I do the surgery, but it isn't just me, it's the whole team. So I need the surgical techs, the nurses, the anesthesiologists. So it's a group effort to do this correctly.
That's what I'm saying. It's not something you can just do right away, turn on the dime,
Right.
you know.
So for me to try to do a case like this on a Saturday night with the B team or with a group of people who've not used to doing it is not the right thing to do. So we delayed until we get our A team, everything's in order, we get all the necessary preparations, all the equipment. There's a ton of very high-end equipment. We use navigation, which is basically GPS in the operating room.
Right. I've heard about this, which is so you can see exactly where you're going,
Right,
just
so-
microscopically.
Because if you're outside in the morning, right, and somebody says, hey, where is east? Well, you say, oh, there's the sun, right, or where's west? But if I put you in the cave and spin you around and says, where's east or west? What do you say? Oh, I have no idea.
Right.
But we're inside the brain, we're inside the
Exactly.
cave.
Right.
And it's easy to get lost. So we have a mechanism where we take scans before surgery.
Right.
We put them in this very complicated high-end servers, stations, computer stations. We register the patient, and we have the ability through trackers to know exactly where we are once we're inside the brain.
And again, I think to myself, our hands are so, and you've got beautiful, perfect hands, but I'm thinking they're so big when you're looking at a brain, especially if we're looking at a pediatric brain, and just the different tools that you're using. And I know that we don't have anything here tonight, and I know that you probably do some of this prepping, but what are some of the tools that you use? You were talking about the catheter. You were talking about literally drilling a hole into the skull. Describe what some of those are, just because it's just curious to me, because we're not just talking soft tissue. We're talking, like you said, we're all bone factories, especially at that age.
Right.
Drilling a hole into the skull, and then that within a couple of years, if not sooner than that, in a small child will be completely fixed and grown over, correct?
Correct.
So some of the tools that you're using in this small hole that you have to do brain surgery, explain to the audience how you do that. That's fascinating to me.
Yeah, it is incredible the work we do. So, especially in the brain, right? So, because every part of the brain is so critical, I just can't just open up the skull and go, let me go in there and find it. No. You have to find pathways, areas where we minimize damage to the patient. And there's specific areas that we can sort of sneak through. Very specialized microsurgical instruments, very fine equipment to do that. There's a special lasers that I use, a gold laser, which is incredible, which pulverizes the tissue, controls bleeding. I mean, all kinds of ultrasound, very high power ultrasound that gets into the tissues, it pulverizes it and it aspirates it. Yeah, so all of that is
all of this
used.
is through this little hole.
Well, it depends. Some surgeries are done through the hole the size of a dime.
Okay.
Right, that's the endoscopy.
And that's what I'm picturing. Okay.
Yeah, that's through an endoscopy.
Okay.
And that's one of my areas of expertise. I do a lot of that kind of surgery. And then there are other surgeries which we're required to make big openings. So back in here, I do have to make an incision back there, and I do have to make a large opening to get in there and to have access to the whole area.
Okay.
The challenge is that we neurosurgeons work in an area that is very narrow, very small, right next to the brainstem. Blood vessels literally the size of your hair, and if I pull one out by mistake, I leave the patient blind, mute, paralyzed.
Right.
So it's pretty tense.
No, it is pretty
in
tense.
there.
I can imagine.
Yeah.
Being in there again, that I can go on all day, and then one time I would love to get some graphics so we can kind of see this. That to me is where some of that happens. So Sandra, as I would like for you to talk a little bit more about your team when we're looking about again, parents. And there's a question we just got here from the audience. Linda, who's 40, we're not telling your last name, but she has a question here. If a child is experiencing loss of balance, so it's nice when they pay attention, right? So, but she said at this point that that right now seems to be the only thing, and it doesn't have an age of the child here, so we don't know. So let's just assume the child is 3. And so it's someone who is able to walk well enough to where if you're off balance, you can tell. Not someone who's so young that, you know, being off balance because they're just starting to work is normal. But is that a symptom in and of itself that they should be concerned about? I know that we talked a little bit about headaches, nausea, etc., but balance in and of itself, could that be neurological? Could that be just equal, you know, it could be a ear issue that we're looking at too, but just in general, if that's one of the complaints from the parents, what might that be?
If it's something new, if it's a loss of balance, I mean, your kid was already walking with, you know, fairly steady gait, and all of a sudden you notice that your kid starts, like, you know, going to the side, bumping into the walls, having frequent falls, you know,
that's definitely something
it's
to get
definitely
checked out.
to get checked out, yes.
Okay. And when they do want to do that, how, like right now, if there's parents listening or if there's grandparents listening, how do they do that? Like, who do they call? Do they need a referral? Do they go to their pediatrician? How is it that they could do that?
Well, there's initially a lot of parents do go to their pediatrician and they bring up the concerns, say, you know, I've noticed that my child has been a little bit off balance, or I've noticed, you know, a lot of frequent falls. Usually referrals come through the pediatrician.
Okay.
They go through them, and then we get the referral, and, you know, we're able to get them in, like, right away.
Okay.
Then we've also had the parents that call directly. You know, it's like, I have a concern, and we can see them too. But most of them do come with a referral, you know, seen by the pediatrician, and that's how they get sent to us.
So when they call directly, they're calling the neurological unit at El Paso Children's Hospital, or how is it? Who is it that they're calling directly?
Physicians, specialists
Okay.
at El Paso Children's.
Gotcha. That's always good to know here. I know this is crazy, but we're already half an hour into the show, and I feel like we haven't touched base on a lot of things yet. But I want to talk about some congenial issues that children are born with, just different deformities, if that's still the word that we're using. But we talk specifically about water on the brain. We talk specifically about brain tumors, but there are a lot of other issues that little tiny ones are born with that you need to deal with as a neurosurgeon. What are some of the most common issues when it comes to that?
So depends on what part of the nervous system,
Yeah.
right? So we have the brain, we have the spine, cervical spine, thoracic spine, lumbar spine. So fortunately, we don't deal with it as much as we used to, what was called a spina bifida.
Oh, yes,
right?
of course,
The
yeah.
spina bifida. So that's a condition in which the bottom part of the spine never closes. And when the baby's born, the spinal cord is literally wide open like a book.
And when in vitro is that supposed to start closing? I remember us talking about this a long time ago. There's a certain month in vitro when the spine naturally starts or should start closing.
Right. So by day 21.
And I remember that
So-
being crazy early on.
So
Yes.
mom does not know that she's pregnant yet. And already the bulk of the nervous system, it's already, the brain and the spinal cord is already formed. Isn't that crazy?
Yes.
Right.
So as she's
it's-
getting her first sonogram, say at month 3, is this something that shows up?
It can, yeah, certainly.
Okay. Okay.
So the nervous system is set up by then. So typically day 18, 16 to 18, 19.
Of the pregnancy.
Of conception.
Of conception.
Since
So again,
conception.
they have no idea that they're pregnant, for the
Right,
most part.
right.
Have no idea that they're even pregnant.
At that point, something happens that doesn't allow the spinal cord to close, right?
we don't know what that
think of
is.
it as like a zipper, right? So we are, I won't get into detail, but we're born, you know, out of 2 cells, become 1.
Right.
That 1 becomes 2, 2 becomes 4, 4 becomes 8, 8, 16, so on and so forth. At one point, one of those cells is going to become all of the nervous system. One of the cells is going to become all of the muscles. Another cell is going to become all of the bones. Another cell is going to become all of the skin, and so on and so forth. But the first thing that happens is the brain and the nervous system closes itself and forms itself.
Interesting.
Following that, then think about it, right? The dura, the membrane that covers it, comes and seals it like a zipper. Then the bones come over
Right.
and bones zip up. Then the
So
muscles
it literally
come.
is layer
Layer
by
after
layer,
layer.
by layer.
Then the muscles come
Uh-huh.
and they close.
Okay.
And then the last thing is the skin comes and closes. But if the nervous system, part of it doesn't close,
Right.
guess what happens?
There's
nothing
no,
else
nothing
comes.
else can close.
And when the baby's born,
Right.
their back is wide open.
Oh my God.
And this can happen anywhere along the spine. It can happen back here. It can happen in the brain. I took care of a ton of kids when I was in the Philippines doing medical missions in the 90s, where literally the entire brain comes through here. Eyes
So
are out here.
what do you do at that point as a neurosurgeon, as the doctor? What is it that you can do at that point? And maybe we can look at 100 years ago, there was nothing that could be done. And then maybe 50 years ago, A, B, and C could have been done. And we can even look at now, because just doing this program, it is amazing to me what a difference a year can make or 2 years can make. So when you were taking care of babies in the Philippines, what were the axis of tools and medicine that you had that can help? What was that? And then what is the difference between having that somebody born tomorrow with these issues and what you're able to do now?
Well, yeah, let me regress back to the spina bifida, right? One of the new things that we're doing, which I think is incredible and fascinating, is that we are doing fetal surgery.
Yes.
So now I don't do that. Specialized centers, there's 3 or 4 across the country, where somewhere in the 3rd trimester, we go in, open up the uterus, go inside, do the surgery, close things back up. So when the baby's born, they don't have that problem.
Right.
The incidence of hydrocephalus seems to go down. So that's something that wasn't available many years ago, right? Now, for any deformity that the patient is born with, we just have to wait and see what happens and fix it on the fly.
Oh my gosh.
The thing that's fascinating and
Yeah.
I love about pediatric surgery and my colleagues in general surgery, in cardiothoracic surgery, and myself sharing this is that if you herniate a disc, right, and I do your surgery and fix your herniated disc in your neck.
Which, by the way, I do need, but yes.
Oh, okay, I'll give you my card.
I'll give you my card.
If Sandra herniates a disc,
Yeah.
if 100 people in this building herniate a disc, it's the same operation. Exactly the same operation, right? If you have carpal tunnel,
Same
same operation.
Right.
Whatever it is, right? But with congenital anomalies, everyone is different.
Right.
You can't open up a book and say, how am I going to do this?
Right.
So you just wait until the baby's born, and you look at it, and you go in, and you just fix it.
You know, you make it sound so easy. You just go in and you fix it. Okay, my mind is in 3, 4 different places right now. So we're looking at going in and fix it. So when you're talking about this baby who literally nothing has closed up yet they're born full term? Are we talking 8, 9 months? So
We try to get them to
we try to get them as
much
full term
around.
as possible. How many babies are you able to save is one word, but also get to where functioning at a relatively normal pattern? How often is that? Like, I don't even know how I'm asking it. I know what I'm trying to say, but I can't. You know what I'm asking.
The answer is we can get about 85% of the kids become ambulators.
Okay, about 85%.
Yeah.
That to me is fascinating.
Right.
If you're describing, because I've seen, we've done these programs before, and we've actually seen the graphics before in the past, and it is fascinating to me because it doesn't look like the organs wouldn't work right. That, and how many surgeries on average would this take? I mean, it can't just be a one and done thing.
Well, typically for the nervous system is 1, with the primary
Right.
closure.
Right.
And then if the babies are born with, again, there's a spectrum, right? You can have a very mild case of spina bifida, and we close it, and the baby, other than the scar in the back, they're perfect. And then you have other babies who are born with very bad deformities because the nervous system didn't develop correctly, it wasn't just that they closed, it's just malformed. It affects muscles, limbs, legs,
Right,
the hips
everything.
are all twisted, the knees are all bent, the ankles, they're born with club feet and all that. Then they need a lot of orthopedic surgery for
Right.
corrections. They,
Right.
We work with a team of
And then there's
urologic
growth
surgeons
plates.
and
You're
all
looking,
that.
like you
right.
said, the bone factories. If there are different types of neurological surgeries, neurosurgeries that need to go along, and then when you're looking at ortho and you're looking at muscular, it just fascinates me how that works and the follow-up. So I guess this is a question for Sandra. When and how is the follow-up? Once Dr. Jimenez and doctors and everybody on your entire team does the magic, then you're looking at, days first, and then getting through the weeks, and then the months following, and then the years following. How is the follow-up done when it comes to, and I know, again, there's so many different cases, but what is the follow-up that you all do with your unit?
Well, we have different clinics. I mean, I don't think we mentioned it, but we do have a clinic specifically for spina bifida. It's the spina bifida clinic that does incorporate ortho, urology. After Dr. Jimenez does the surgery, we follow them up 2.5 weeks after surgery in our office.
Okay.
And make sure everything looks good. And then after that, we do pass them on to the spina bifida clinic too, so that the patient can get seen by everybody in the team in one visit, instead of having to send them to ortho and then to uro.
Right.
Everybody gets to see the patient in one visit,
Right.
including Dr. Jimenez. And that's where they get physical therapy appointments. That goes on. Usually they see them after a month, and then I'm thinking it's 3 months, and then 6 months, and then so on, depending on the needs of the patient.
Okay. And the needs of the patient too. I mean, some you're looking at following up for years and years.
Oh, they're ours for the rest of their
Yeah.
lives.
You
Yeah.
throw me, because I remember last time we talked, and I know it's been a while, but I feel like there's always a story, and there's always that success story, that story that you remember. You were talking about this baby that had water on the brain. I'll just use again the easy way of talking about it. And she is still living, and parents are taking care of her or him today. Again, I'd rather not know her or him, but what has been a story of yours that has been a great success story? Like, I remember this, and this is how it went down, and I know how this child is doing today.
Oh gosh.
Of all the many that are out there, I'd imagine you do.
Yeah,
I'd
yeah.
imagine you do.
Doing this for 30 years,
Yeah.
God blessed me with doing this work for Him.
Yeah.
And so I've had so many wonderful opportunities, but it depends. There are some with tumors, which there's so many of them, right, Sandra, that we've seen here. Others are traumatic. That's another area we take care of.
We haven't even
is
talked about trauma.
Trauma.
That in and of itself, trauma and neurosurgery when it comes to trauma, and then pediatric. So you know what, since we haven't touched base on that, let's talk a little bit about that, because we could talk a little bit about prevention when it comes to trauma, but throw a case study out there that you really saw a great turnaround on how you treated a trauma patient.
Well, we just had one not too long ago.
Okay. And tell us what it was. Was it a car accident? Was it a
Yes,
fall?
it was a car accident.
Okay, it was a car accident.
So this young gentleman, 16 years old, 350 pounds, 6-something, football player
Goodness.
up in New Mexico, drives his Bronco, don't know exactly what happened, rams it into a tree, right?
Right.
When you see, if I show you the pictures, you say there's absolutely no way that this person could have lived. The steering wheel, which is here, ended up about here.
Oh, jeez.
The car completely mangled, and because there's no way that this individual could have survived.
Right. Oh my
They
gosh.
come in, they take them out. He's kind of still talking and gets out, goes to a hospital.
He's still talking, gets
Yeah,
out.
right.
Okay.
He goes to another hospital in New Mexico, and then they're moving him around. Eventually, he gets transferred to our medical center here. We'll come in to find out. He goes, well, let's scan his spine. His spine in the back was literally, the spine was like this and like this. When you look at the scan, you said, this patient has got to be paralyzed. Where's
But
the
he was
spinal cord?
walking.
Well, no, he was in bed,
Okay.
you know, intubated
Oh,
and
I
all
see,
that.
I
Maybe
see.
he
But right.
broke his legs and all
Okay.
that.
Okay.
But yet this kid still, he knew how to sign. So he was signing to his mom and dad and us. Well, we come and find out, oh my God, this kid, we're moving him around. His spine completely broken. I mean, this kid should have been dead on the spot.
Huh.
And if he didn't die, he should have been paralyzed.
Right.
We come over, we take him, we fix him, we take him to surgery. He literally walks out of the hospital 2 weeks later, comes to our clinic. He looked perfect. I mean,
I know
it's
you
like-
guys can't see Sandra over here, but Sandra's got this big smile on her face and just nodding like she absolutely remembers this happening. So
But
2 weeks later.
Yes, the kid's walking. I mean, this is tells you fate.
Yeah,
This was not his time to either die or be paralyzed.
right.
And yet somebody may trip with a banana peel and die on the spot.
You know, I've had a doctor on in the past, and sometimes he says, sometimes we don't have the answer, sometimes only God has the answer as to why this happened or that happened.
Right.
And I guess this is one of those times.
Yeah.
And so he was 16, and this was in New Mexico, so you've been here, this was the last 2 years in your
This
time
happened
frame here.
like a month ago?
Oh my goodness gracious.
Yeah, we
Yeah,
saw
you
him like
came-
2 weeks ago.
Has
He
he
came to
baked you a
clinic.
cake, bought you dinner, anything like that?
No.
My gosh.
Just seeing him walk and smile is all that I need.
Yeah, I love that. We have a couple of questions here from the audience before we start going. So what I'm going to do is stop our program as far as question goes from the audience in a couple of a couple of minutes, and just see if there's anything that we haven't covered yet that you want to talk about, and same thing with you. But in the meantime, there's a question here about what is the progression, I'm reading this cold, sorry, what is the progression of a cavernous hemangioma in a child, and is there a treatment for this? Am I saying this right?
Cavernous hemangioma.
Yes. So that is the question from the audience.
That's a very good question.
Yeah, that's
So
what I'm
a
not familiar with.
cavernous hemangioma is a vascular malformation. So we have arteries that turn into very small little arteries that turn into capillaries, which then exchange the oxygen with the red cells, and then become little tiny veins, bigger veins, and then go back to the heart, right?
Okay.
A specific pattern. If in utero there is a maldevelopment, sometimes you go straight from an artery to a vein, and there's no capillaries. Those blood vessels tend to be very friable, and they tend to bleed.
Okay.
If you look at them, they look like little mulberries. Look, that's what they look
Yes,
like.
I'm actually
right?
familiar with that. I had a nephew that had this issue. Yes.
So,
okay.
so they can bleed. Now,
Yes.
they're not like aneurysms where they can blow and kill you on the spot,
Right.
but they can bleed. They can cause large hemorrhages. They typically, if they're located on the cortex, they can cause seizures. So everyone is a little different. Oftentimes we just follow them. If they don't cause problems, we leave them alone, particularly if they're in very critical areas. But if they tend to bleed or rebleed, or if the patient has seizures, then surgically I go in and remove them.
So here's the question. How do you know in the first place this person has this condition? Do they present with a headache? Do they present with imbalancing? Do they present, like you said, if they're not causing an issue, you kind of watch.
Right.
How do you know this is happening in the first place?
It's location, location, location.
Ah,
Right.
okay.
If I have one here,
Right.
I may go to my grave and never know it.
Uh-huh.
But if I have one over my speech area
Right.
and it bleeds a little bit, then I can't talk. If I have one in my brainstem and is an area that controls my hand, then I go
Right.
paralyzed. See, it depends on where it is.
You know, I have a story to tell you after the show because we don't have enough time, but I'll quickly say I have a nephew that just won a bronze in the Olympics for Germany, and he had this condition 2 years ago.
Really?
They thought he was going to die, and the surgeons, he was in Palma at the time in Spain, they did what you're doing, but whatever they did, they saved his life, and he's better than ever. So that's just gave me goosebumps when you're talking about this. Another question here from the audience, and this I'm going to direct to Sandra, but both of you I'd like to chime in on this. A couple in their late 30s are trying to get pregnant. You know, I had my first baby at 30. Good job, good job. Hang in there. Is there anything that they can do to decrease the possibilities of neurological issues in the fetus? Again, as parents start getting older, there are these questions. That's a question I'm throwing your way. If you'd like to throw it to Doc, you can do that too, but I'm just throwing it out there because I want to respect the questions from the audience.
Well, making sure that the mom doesn't have folic acid deficiency. I mean, that's it decreases the chances of spina bifida. Basically, that's the
The
one
prenatal
thing.
vitamins, make sure that they go to many
Right.
visits.
Folic acid, folate.
I love that,
You have
folic
to-
acid.
You have to take folic acid.
I know there's orange juice that is fortified,
right.
vitamins.
But little pills with folic acid. Any female who could possibly get pregnant, regardless of their age, they should be on folic acid.
Okay.
Because when I was a resident, many, many moons ago, we used to have literally dozens of these kids with spina bifida, they're born almost every other day we had a kid. I mean, it was just massive numbers. And then we realized, medicine realized that it was linked to a folic acid deficiency.
Interesting.
We
Okay.
began giving women folic acid and the incidence will literally almost drop. Now I see one a month, maybe once every few months, which is great. So if you're, to answer that question, take folic acid. Another one is avoid toxins, i.e. alcohol,
Right.
smoking, all that stuff.
Right.
Well, we're assuming that, they're not doing that.
Right.
But avoiding that are the main two things, and a good diet, of course.
I remember being pregnant at 29, and folic acid was the answer that was kept throwing because I was an old first mom. I'm 54 now, so I don't think that can happen. But we are at that point in the show where I'd like to stop questions from the audience. And Dr. Jimenez, is there anything, I know there's a lot that we could still cover, don't get me wrong, but is there anything that you'd like to talk about before this show finishes? Because I know it goes so fast. And we've got a good 10-ish minutes that we can play with. Actually, we have 5 minutes we can play with. Thank you very much. We have about 5 minutes we can play with, which is actually a long time.
Yeah.
You don't think so?
Right. So, no, I think simply for people to know that we have this service available to our community, which we didn't have before. I think it was great of El Paso Children's Administration and everyone to think about bringing someone like me here. And my original goal was not just to come here to do cases, because if I leave in whatever years, then you'd be back to square one, is to build programs. And my goal to work with the hospital and the community in general is to build a neuroscience program where we can take complete care of the patient, and not just one person, but a group of us, and that this can go on ad infinitum. As I mentioned earlier, we're hiring a second pediatric neurosurgeon. We're also in the process of bringing in a high-level pediatric neurologist, and epilepsy is an area of
That's
a
a
lot
big
of
one.
interest. See?
Right,
So
right.
what we're planning on doing is setting up an epilepsy program. That's something
And there
that
isn't
affects-
one here that I'm aware
Well,
of.
no, not
Okay.
well. We have a neurologist who treats epilepsy with medicine, and he
Right.
does a great job.
Right.
So in epilepsy, let's finish with that. So epilepsy is where the certain part of the brain gets activated and causes the problem. There are two main categories. One category is what we call medical, which you can only treat it with medicines. And then there's another category in which maybe a mass, a cyst, a tumor, or some kind of deformity causes the brain to get irritated. Well, surgery, we
And
go
that's where
in,
the surgeries that
right?
is-
We
the
go in,
seizures happen.
we take out the causative effect and cure
Okay.
the epilepsy.
Okay.
So we're in the process, and we will within a year have a full-blown epilepsy program,
Huh.
doing with equipment, doing the latest and greatest, and I'm very excited about that.
Well, I know that it's a very needed thing. In epilepsy, it's just one of those, all of us remember the kid in school that had seizures. And, that's, for me at least, was my first education of what do you do with someone who has a seizure? Do you leave them be? In fact, Sandra, I'm going to ask you that right now for people who are listening. If you know someone who's having a seizure, if you see somebody having a seizure, what do you do as a bystander?
Well, make sure it's safety, that they don't hit
Like
their
get all the
head.
chairs and tables and everything out of the
Yeah.
way,
And make sure that they don't aspirate, that they don't choke on their own secretions, you know.
and how do you do that? Do you turn them to the
Turn
side?
them to the side if
Okay.
you can.
Okay.
Yeah, if you can. But basically it's just safety.
Okay.
You know, make sure that they don't hurt themselves.
Right. I want to ask you this question before we wrap up, and just about the programs that you guys have going on, because I know that's something that you're very involved in. And we've got a little bit of time, but can you describe what's happening over at your place right now?
Well, we have a lot happening.
I know
and
you do.
Dr. Jimenez has so many things that he wants to, you know, get done. Like I mentioned earlier, we have the spina bifida clinic that is available. They also started a scoliosis clinic, which, you know, a lot of kids, younger kids, have scoliosis. You know, we have a great doctor, Dr. Heidemann, that is
Dr. Heidemann, yes.
that's doing that clinic. We also have brachial plexus clinic, which is when babies are born, you know, injuries can happen to their nerves. Dr. Diamond and Dr. Jimenez are doing that clinic. We also have a craniofacial clinic where they see kids with plagiocephaly, and, you know, Dr. Yates sees patients with cleft palates and all that.
Yeah.
And we are planning on a plagiocephaly clinic, you know, to see patients just for our, you know, a lot of deformities for the, you know, positional, that we see a lot of patients like that at our clinic, that if we could just see those in a separate clinic, I think we would be able to see more patients.
So bottom line, you're trying to look at these specific issues that are in the grander populace and trying to be, you know, epilepsy here, and we've got different programs going on. And so again, how long has the El Paso Children's been open?
10 years.
10 years. So there's a lot that's been going on in these 10 years. Really, congratulations to everybody. When I say doctors to nurses, but again, it's the entire team, especially in this time of COVID too. And again, we're a medical show, and we're not telling you to go get your COVID vaccine, but we're encouraging it for sure, to make sure that there are fewer hospitalizations and the disease doesn't get too far in that situation. So I want to say thank you very much to El Paso Children's Hospital. And again, found my paper. Josh, thank you so much for your questions. They have been wonderful coming this way. And again, to Dr. Jimenez and to Sandra Flores and the El Paso Children's, like I said, and the El Paso County Medical Society, who's been around for, gosh, you've been around forever, but doing the show for more than 25 years. If you are looking at getting the COVID vaccine, you can go to the Civic Center at any time between 8 and 3 and get that done. Thank you so much. I'm Catherine Berg, and you've been watching the El Paso Physician.